All right. Let's go ahead and get started. It is my pleasure to introduce Dr. Katie Gielissen, who's an associate professor of medicine and pediatrics and the program director for our Emory Combined Internal Medicine and Pediatrics residency program. She earned her medical degree at the University of Chicago before completing her combined med-peds residency at Yale. She then completed a 2-year MedEd fellowship and master's in MedEd in 2018 and then served as the associate program director for the Yale internal medicine program, as well as associate clerkship director for their internal medicine clerkship. For 6 years, she served as co-editor of the Yale Office-Based Medicine and Ambulatory Curriculum used at over 300 programs across the country before coming to join us in 2023 to start the MedPeds program. Her scholarly work is focused on competency-based medical education, entrustable professional activities, and improving the ways we assess and support learners in clinical settings. She also teaches nationally about MedEd scholarship through two key faculty development programs, the Society of General Internal Medicine's Medical Education Scholarship Program and the Association of Pediatric Program Directors Scholars in Medical Education Research Fellows Program. Thank you so much, Dr. Gielissen, for being here with us today.
Thank you very much for that generous introduction. It's such a pleasure to be joining everyone today. I don't know if I'm sharing my slides anymore. Maybe somebody can tell me if I
You
am.
are. We can see them.
Oh, perfect. Okay. I cannot see them in front of me, which is fantastic. We'll figure it out. I'm really pleased to be able to talk about a topic that's near and dear to my heart, obviously, as the program director of the MedPeds program here at Emory, which is my specialty. It's a little bit of an unusual talk for medical grand rounds to talk about a specialty. That was the ask that I was made today. But I'm hopeful that I can make this relevant to the many different stakeholders that are on this meeting today, including trainees. Many of you will be working with our MedPeds trainees, and you'll want to know what they're capable of and what they bring to the table. Many of you are teaching faculty who will teach our trainees in their internal medicine rotations or subspecialty rotations. And many of you are division directors, are part of different aspects of the clinical care within the Emory and Grady and children's systems. And you might be thinking about how a MedPeds physician could fit into the clinical care goals of your specific division. So I'm hopeful that I can make this relevant to many different folks today. I have no conflicts of interest to disclose today. And here's what we're going to be talking about. So the plan is to describe the history and training structure of combined internal medicine pediatrics, dispel any common myths or misconceptions about MedPeds. I'm going to be talking about some specific clinical niches, and I'll be welcoming two other faculty to talk about the specific areas that they're working on to ground what we're going to be talking about. And then, of course, I'd be remiss as a program director to not talk about my own program and how excited we are to be able to bring this new training to our institution. So like I mentioned, I will be joined by two other faculty in MedPeds, just to give a clearer picture of the different clinical spaces that we can enter. So Dr. Tarun Arora is a quadruple board certified MedPeds hematologist. And Dr. Ronnie Rutledge is a MedPeds hospitalist, and they're going to be talking about some of the clinical initiatives that they are involved in our system. So what is MedPeds? I know many of you might have trained at institutions that do not have MedPeds, including our own until recently. MedPeds is an integrated residency in two specialties, internal medicine and pediatrics. So we do basically two residencies in one. As such, we are board eligible for both the internal medicine and the pediatrics board exam at the end of our training. And MedPeds docs tend to use that training to a number of different ends. So sometimes it can be lifespan care in the primary care or hospital space. Sometimes it can be special populations, so especially those who are born or with childhood illnesses. And then lastly, transition care. So thinking about that transition from pediatric into the adult spaces. And we can fill any number of these spaces, and some of us fill up several of these spaces simultaneously as MedPeds physicians. Here is a list of MedPeds faculty and fellows who are already at our institution. And if you are a MedPeds trainee, if you're MedPeds trained at all, I encourage you to identify yourself in the chat. There are many, many of us who already work at Children's, at Grady, and at UH. And it actually was quite natural and easy to be able to build a program here because there's so much MedPeds presence already in place. And so I'm really grateful to all of them. I thought I'd start by just talking a little bit about where our specialty came from. A lot of people are not aware that we are a very old specialty. People have a conception that we might be brand new, but let me tell you a little bit about our origins because it helps us to understand where we're going in the future. So some of you might be aware, before World War II, before the 1960s, there weren't really specialties. Many physicians did 4 years of medical school and then 1 year of internship and became what was called a general practitioner. It wasn't until the 1930s that specialties started to emerge, and many of the specialties are the ones that we're familiar with today. So pediatrics, internal medicine, et cetera. After World War II, there was a massive shift towards specialty training. During the war, specialization became a really important aspect of care, and those who were specialized were more likely to be higher ranks in the military. And so after the war, many specialties just ballooned in popularity quite quickly. So by the time 1966 ran around, there were only about 15% of physicians who were trained to be general practitioners anymore. Many of those, the rest of the physicians were becoming specialists. And around that time, in order to start to think about how to create a new primary care specialty in place of general practitioners, family medicine was starting to be piloted. But simultaneously, there were conversations amongst the internal medicine and the Peds leadership that there needed to be a specialty in the primary care space, in the general medicine and Peds space that had really strong training on both sides. So in 1967, the American Board of Internal Medicine and the American Board of Pediatrics met and created and approved dual training in internal medicine and pediatrics. So we were already a specialty in 1967. And as I like to say, we're as old as family medicine, which many people are surprised to hear. And I like some of the meeting notes from that, or meeting minutes from that meeting. They specifically said that people who do this dual training are going to be few and far between, and they will be, quote, unusually good candidates. And I think the unusual moniker is a pretty good label for MedPeds in general. But it didn't really take off. So this combined training, not many people did it at all, mostly because it was an advertising issue. So you heard about it through word of mouth. It was actually quite a complicated process to be able to do the training. You had to first do an internship that was 6 months of medicine, 6 months of peds, and then apply to do the dual training in internal medicine and pediatrics afterwards. And only a few institutions even entertained the notion of doing this combined training. So it was quite unusual for people to choose to do it. And the booklets where residency programs and specialties were listed didn't always include it. So the American Board of Pediatrics did, but the American Board of Internal Medicine did not. Thankfully, we had some pioneers in our field. So first was Dr. Lawrence Kutchin. He was the first one to ever do combined training in internal medicine and pediatrics. He graduated in 1969, and I had the honor of meeting him at our 55th anniversary a number of years ago. And then secondly was Dr. Frank Jeffrey Marks, who was the first to do what is traditionally known today as MedPeds training, which is 4-year training. And he achieved his board certification in 1975. And we're very lucky to actually have the recorded words of Dr. Lawrence Kutchin. So I'm going to share about 2 minutes of him talking about why he chose to go this unusual route that no one had ever done before.
Well, I was in school at the time. I was infected with a bug of primary care and community-oriented primary care that was being taught by these doctors. And I looked around me and realized I really wanted to be a primary care physician, and I wanted to be a well-trained primary care physician. I didn't want to just take a rotating internship and become a general practitioner. No reflection on them. They hadn't had the opportunity, but I didn't want to go that route. So I took the opportunity to make an appointment with the chairman of the Department of Internal Medicine, Dr. Charles Burnett, when I was in my third year of medical school. And I went to Dr. Burnett, and I shared with him the fact that I was concerned that I didn't see a training track to become the kind of doctor I wanted to be. And we had a discussion, and he said, son, you got three choices. He said, you can quit. And I said, I don't want to do that. And he said, well, you can go into a narrow specialty, and I expect you're going to be bored to death by the time you're 40, knowing you. He said, or you can stay and you can tailor your own plan, and you can make some waves and work and do something different. And I said, well, what do you have in mind? He said, well, a lot of us have been concerned with the fact that young folks like you are worried about this process. You're having difficulties because you don't see how you can be a general physician and have board certification. And you and we are pretty sure that board certification has become more and more important over the years. And so we've been talking about what we ought to be doing to try to help train primary care physicians. And we've created here at Chapel Hill, we've created a mixed internship that is 6 months of internal medicine and 6 months of pediatrics. And if the doctor wants to layer a little bit more onto that, he could, but we are encouraging them to go on and take full training in internal medicine and pediatrics because we think the primary care physician should be well-grounded in internal medicine and pediatrics, most of all, if they're going to go out and practice.
So I think he exemplifies a lot of the MedPeds spirit. He's the first MedPeds physician. The idea of making waves, the idea of a single training track not being quite the right fit. And he truly set the stage for a lot of other trainees in his wake. So after that time period, MedPeds did grow pretty tremendously. So by 1976, the term medicine pediatric had been coined, and it was listed in the booklets where you could see residency training programs. By 1980, there were 5 formal programs listed in the ABP directory, but there were many, many informal programs around that time. As evidenced by 1986, there were 67 programs listed. By 1987, it was recognized that because there were so many different programs and they all had different training structures, some guidelines needed to be introduced. So there was a little bit more uniformity in the training. And so that was introduced in 1987. By 1998, there were 106 MedPeds programs with 556 positions. And that was the peak. That was the most programs that we had ever had as a specialty. Followed by 2003, when we became separately ACGME accredited. Previously, we had been accredited through our sponsoring programs of internal medicine and pediatrics. But 2003 was really a milestone for us as a specialty because it recognized that we were a separate specialty that required different requirements and integration between the two departments in order to support trainees. Unfortunately, it had a little bit of a downstream effect on training programs in that a number of these training programs were unable to meet these specific requirements. And so quite a few programs shut down in the wake of the 2003 ACGME accreditation. So after having 106 programs, we are now down to 80 programs nationwide. So you can see that MedPeds programs are pretty regionally distributed. We're mostly on the east side of the United States. There are very few programs on the west part of the US, primarily because family medicine is so prominent in that part of the country. And until about 3 weeks ago, we at Emory were the newest MedPeds program. We were the 79th program to exist in the last couple years. But I'm very excited to say that Northwell Hofstra were recently approved as a new program, so we very much welcomed them into the MedPeds community. So there are now a total of 80 MedPeds programs across the country. And we're a very well established specialty at this point. So we were the very first combined specialty approved by a board. I believe we were the first ACGMA accredited combined specialty, and we have the most combined trainees currently active in the US, and by far and away the most graduates. So we have existed for a long time, and we have many people practicing out in the world. One of the things that has grown along with us is our identity. As MedPeds physicians, we very much value our versatility and our flexibility in our careers and our ability to care for patients. And as part of that identity, one of the things that we've established is many different pathways for careers. So many of us serve as primary care physicians, and we take care of the full family, especially focusing on children with special healthcare needs because of our robust pediatric training. Many of us go into the global health space because of our versatility, taking care of adults and kids. Population health is a really common path. Survivorship care, so thinking about the impacts of treatment of illness in childhood affecting adult outcomes. We have very strong intensive care training, and then we're very natural fits for other things like rural health and adolescent care. We're also growing slowly, slower than medicine. So this is a graph of the number of graduates in categorical internal medicine versus MedPeds. So you can see over the last 10 years, internal medicine has grown tremendously, about 40% in categorical internal medicine graduates versus MedPeds, which we've seen about a 20% growth in the number of trainees that have graduated out of our programs. The American Board of Pediatrics doesn't like me to share their data, but I will say that the growth in pediatrics has been quite similar to MedPeds. It's about a 20% growth in the number of graduates from the categorical ped specialty. So I thought I hear a lot of myths about our specialty in MedPeds, and because many of you will be working with our trainees, and many of you already do work with faculty who are trained in MedPeds, I thought I would take this opportunity to share with you a little bit about things that I hear often that are not necessarily true about MedPeds graduates. So one thing I often hear is MedPeds is the same as family medicine. I often hear it's not possible to learn both medicine and pediatrics. And the most common thing I hear is that most people end up choosing one or the other in the end anyway. So let's talk about each of these one by one. So first, MedPeds is quite different from family medicine. Our training is very different, and family medicine has very different strengths than MedPeds. Family medicine is a very primary care-oriented specialty. They tend to have a lot of strengths in the primary care space, specifically around obstetric care, as well as procedural care in the ambulatory space. They have their own separate board, whereas we sit the internal medicine and peds board. The amount of inpatient exposure is quite different. We have very extensive inpatient exposure, including the full repertoire of inpatient rotations that a medicine and peds resident would experience, in addition to all the ICU rotations that they would do, MICU, PICU, NICU, and CCU. We have a full 24 months of pediatric exposure, which is quite different. We do not have any real obstetrics exposure. For our continuity practice, we both are required to learn continuity skills in the primary care space during our training, but we are very much required as part of our training to have an equal balance between adults and children that we see in our clinics. And lastly, the career options are a bit different. We have a lot of different fellowship opportunities available to us, which I'm going to talk about in a slide or two. The practice patterns in the primary care space are different as well between MedPeds and family medicine. So these are very old data. There aren't any newer data that I could find to explain practice patterns. But as you can see, for MedPeds physicians who are primary care doctors, they see a wider scope of age in their clinics as opposed to family medicine, which tends to trend a little bit older. The next myth I hear is that it's not possible to learn both. And the best evidence I can give is regarding board passage rates between internal medicine, med peds, and categorical peds. So these are the national board passage rates for the last year, 2024. And as you can see, med peds passes their board exams at similar and sometimes higher rates than their categorical colleagues. And the trends come and go, but it's about even almost every single year over the last 10 years. And then the last thing I hear is most graduates end up choosing to practice either medicine or pediatrics in the end anyway. Recently, a survey went out to ask this question. So in 2022, a large group sent out a national survey to the various professional groups that MedPeds physicians tend to occupy, which includes the AAP, the AMA, et cetera. And they asked this specific question: do you take care of adults and kids? And while the population that were studied, there's some biases inherent in that. About 91% of respondents said they maintained their internal medicine and PEDS board certifications. 89% said they continued to practice across all ages. And 97 said they were satisfied with their training and would 90% said they would do it again. So a large number of people managed to find a way to practice both medicine and pediatrics. Similarly, when we look at board maintenance, so these are individuals who are up for their 10-year renewal after getting their internal medicine board certification. MedPeds graduates maintain their internal medicine boards at similar rates to internal medicine faculty. I often get asked what people do when they're done with MedPeds training, and the answer is basically anything. But here are some of the things that we've seen as trends in our graduates over the last couple of years. So this is from our program director survey, which gets sent out every single year and has a very good response rate. And they explain a little bit of the career choices for graduates from 2023, which is pretty on par over a year-to-year basis. So a large number of us go into either private outpatient practice or academic practice, which usually is a combination of primary care, med peds. About 10% of us go on to do what's called a combined or med peds fellowship, which I'll explain a little bit more in a slide or two. 21% go on to do an internal medicine fellowship. 9% do a peds fellowship. And 15% go on to become a med-peds hospitalist, and 10% become an internal medicine hospitalist only, with the remainder doing things like chief resident year, a peds hospitalist only job, or global health or some other career path. So as you can see, there's a wide variety of career choice for graduates, but a large number of folks choose to do some kind of combined job. And many of the folks, even if they choose to do a fellowship in internal medicine or pediatrics, find a way to cross over between the other discipline once they find their first faculty appointment. As I mentioned, subspecialty fellowships are available to our trainees. So since we are eligible for both the internal medicine and pediatrics boards, we can apply for any internal medicine or peds fellowship upon graduation. And some folks even choose to do a combined fellowship. That could either be a fellowship that's naturally combined, like allergy immunology, but it could also be a fellowship outside of the match, like combined hematology, which Dr. Aurora will be talking about in just a little bit. Knowing which fellowships MedPeds people choose to do is really helpful. So this is fellowship matches over a 3-year period for MedPeds graduates. The blue bars signify internal medicine fellowships, the red bars signify pediatric fellowships, and the purple bars signified combined fellowships. And you can see the most common fellowship of all is Palm Crit Care. I think there's a little bit of a trend towards this because after the pandemic, there was an increased number of interests in Palm Crit Care after that incident. So that might be a little bit of a blip. But you can see the most common combined specialty for med-peds folks is allergy immunology, followed by combined infectious disease, followed by palliative care. And I'll share that we actually do already have combined fellowships here at Emory. So these are the fellowships that are already available at Emory that MedPeds people have chosen to do and trained in. Actually, allergy immunology, we're waiting for the MedPeds folks. Dr. Jerry Lee is very excited to recruit a MedPeds person. So there's already lots of training opportunities here and available for MedPeds. Next, I want to transition to talking about how we as physicians can enhance our hospital systems in various ways. One of the things that we know is that the landscape of medicine is changing tremendously. So first, thankfully, due to advances in the care that we deliver, pediatric survivors are now adults. Things like congenital heart disease that used to kill children, they're now living on to having children of their own. And you'll see that some of these are particular strengths here at Emory. So in particular, cystic fibrosis, we're one of the biggest cystic fibrosis centers in the country. Similarly, sickle cell disease is a particular strength of ours. And then simultaneously, many adult diseases are encroaching into the pediatric space. Unfortunately, as the obesity tends to be increasing in children, we're seeing more hypertension, more diabetes. And most of this care was previously delivered by pediatric subspecialists, but as the incidence has increased, the care of these particular conditions are falling more and more on primary care doctors. And MedPeds people are very well positioned to be able to address that. And I like this quote from Dr. Vidal saying, people with the broadest perspective and the most comprehensive knowledge will lead the transformation in healthcare. And I think MedPeds is well situated for that. The other area where we lend our expertise is in the transition from the pediatric to the adult space. We recognize that those who are young adults are undergoing a very well described but poorly understood developmental stage called emerging adulthood, where they're expected to have increasing responsibility, but simultaneously in their developmental stage, they're working on their own self-efficacy. They might be taking more risky behaviors at the same time. Simultaneously, they're undergoing huge life stage changes. So they're going to college, they're leaving their parents' house for the first time, they might be getting their first job, they may be having children of their own. And then for those who were diagnosed with a childhood condition, sometimes this life stage can coincide with disease-related complications. So this is the time period where patients with congenital heart disease might develop arrhythmias, or where people living with cystic fibrosis might develop diabetes. So multiple things coinciding during a time that they're most vulnerable. And so we often see this perilous jump from pediatrics to adult medicine as a really high risk period in an individual's life, especially somebody living with a chronic disease. And it's an area where MedPeds people can often put a lot of energy and focus and be quite helpful. There are a number of times where you approach a patient in a particular way and it really resonates strongly with them. And I think one of the biggest transitions that's difficult for many of our families is switching from peds to adult medicine means switching from family-centered care to more person-centered care. And both approaches are perfectly relevant and very well used in each of those domains. But that transition can be very jarring for many families, especially individuals with conditions like autism or intellectual disability or developmental disability. It can be very hard for those families to make that transition. So this is my opportunity to talk about transitions of care, or to flip it over to someone else to talk about transitions of care. So I'm going to invite Dr. Tarun Arora to talk a little bit about his work in the sickle cell clinic at Grady and Choa.
Yeah, great. Thank you so much. So, good afternoon, everyone, and thank you so much for this opportunity. I really appreciate it. It's kind of exciting to tell you what I have been doing for the past 8 years of my life since I just finished training a year ago. and I'll try to condense that down into 4 slides. But it kind of just echoes exactly what Dr. Gielissen was talking about earlier, that, as a med-peds physician, I have been so blessed to be able to work across the lifespan. I work globally, I do medical education. So I'm just going to give you a little snippet of what one med-peds person can do. Next slide. So growing up, just to echo a lot of what has already been said, but I had never heard of it. I'm born and raised Georgian, and up until this very, very year, we did not have a med peds program in the state of Georgia. None of my physicians, I think, were med peds, and so I was just never exposed to it. And when I heard about it in medical school, I was like, that just sounds like family medicine. And thanks to people like Dr. Gilson, that myth was quickly dispelled. Next. And so why I chose MedPeds was once I learned a little bit more about it, and I learned that I love taking care of pediatric patients, I love taking care of adult patients, and I really find it challenging to take care of adolescents. I said, let me take on this challenge because I'm rotating on the pediatric side, I'm rotating on the adult side as a medical student, and I'm seeing the same disease but treated very differently. And the reasons are because we as MedPeds folks and any practicing physician knows that a child is not a small adult and an adult is not a large child. There are differences. Although if you ask my family, I think they still think I'm a large child. But from a medical standpoint, very different bodies, very different physiologies. And so because we as MedPeds people are so attracted to challenges, I told myself I want to learn everything I can about the pediatric physiology and everything I can about adult physiology and everything in between, because I think that'll really set me up nicely to pick something within the lifespan disease, such as a chronic illness, and really hyper focus on that. Next. So just a little bit about my journey so you can know about how amazing it is to have a new MedPeds program in Georgia. So I went to the Medical College of Georgia. So, hats off to anybody who's an MCG grad. It is still MCG, it's not at Augusta University. It's not Georgia Health. It's none of that noise. It is MCG till the day I die. Because I was limited by not having any med peds in Georgia, I wanted to venture out to where I could get a really good education. And as mentioned previously, or as maybe you saw on the map, a lot of the med peds programs are focused in the Northeast and then the Midwest. And the Midwest particularly has a very strong history of med peds. And so I was very fortunate to go to University of Cincinnati, also Cincinnati Children's, where I met my now wife, and I got to learn about MedPeds a lot more from some of the leaders in the field. And then I really got obsessed with hematology and specifically sickle cell disease. And this was the chronic illness I chose to focus the rest of my career on because I would rotate at Cincinnati Children's where I saw phenomenal care of an individual with sickle cell on the inpatient side. I would literally walk 20 feet across the street to the University of Cincinnati, and I was like, huh. Things are done a lot differently here. Maybe as a MedPeds person, it behooves me to help bridge that gap and focus on transitional care of individuals with sickle cell disease or other chronic illnesses. And for that, I went to Memphis, where they have a very high population of sickle cell, but also some of the best leaders for sickle cell disease, both on pediatric side at St. Jude and then the adult side at University of Tennessee. And after that, Emory was kind enough to offer me a job back in my hometown. Next. So you can click one more, Katie. So a little bit about why I decided to focus on sickle cell and really dedicate what I hope to be the rest of my career on it is because, we all in the audience are, I would imagine, familiar with sickle cell, but if you're not, you can take a look at the bottom left. Distilled into one tiny little icon is what sickle cell is in a nutshell, which is where the healthy RBCs, once they deoxygenate, they're forced into the sickled shape. And the sickled shape then can go on to cause numerous problems within the body through two major pathways: vasoocclusion, where they block the blood vessels, and then hemolysis and inflammation, which happens after they lyse. And what's shown here is a slide that is as old as time, and it was done by my mentor, Dr. Jane Hankins, who's actually a MedPeds trained physician in Memphis. Although she did the MedPeds the long way, she did a full pediatric residency, then a full internal medicine residency, and did fellowships in both. But to each their own. And she was one of the first people to just really sit down and recognize that as our individuals with sickle cell age, from infancy to childhood to adolescence and on, the number and the acuity of complications inevitably gets worse. And what's also interesting is that you'll note what you see on the right side of this chart in the adult and young adulthood slides. Those complications are pretty different than what you would see in a baby or a young child. And so, for this reason, I really wanted to pursue this dual hematology fellowship where I could learn everything I could about a pediatric individual with sickle cell, and then learn everything I could about an adult with sickle cell, and then think about that time in the middle, which Dr. Gielissen alluded to already, that transitional time period where complications are increasing, the disease is getting severe, but at the same time, that teenager is, having hormones. He or she is going off to college maybe or starting a new job. They're starting to live independently. I, gave a lot of issues to my mom when I was a teenager and going into young adulthood. Now take that, an already troublesome child, and add on a chronic illness, which may or may not keep you in the hospital, even 2 to 3 months out of the year. So it adds this extra layer of vulnerability and a really intense and scary time for these individuals. So that's why I chose to focus on adolescents with sickle cell disease as they transition. Next slide. So a little bit about what I do here and what I've been so fortunate enough to work with other colleagues on is developing and enhancing the transitional care model that we have as our individuals with sickle cell move from the pediatric to the adult care world. So as shown here, we have a very large population. In fact, Georgia has the third highest sickle cell population in the country, with well over 4,000 individuals in the greater Atlanta area. And CHOA, which includes Arthur M. Blank, Scottish Rite, and Hugh Spalding, but specifically Hugh Spalding and Arthur M. Blank, are really the only pediatric academic centers, and Grady is the only adult academic center. That's not to say that folks that practice regular hematology can't see individuals with sickle cell. They can, but we are the only comprehensive academic institution. The sad news is, and this is not, sickle cell is not alone in this, but we think, and I have a study going on, give me about another 2 years, I'll give you the exact number, but we think it's only 40 to 60% that successfully make it from the pediatric world to the adult world. And that's tragic because I mentioned to you that so many complications arise during that adolescent young adult age range. And if we could capture those young individuals, keep them in the comprehensive care clinic, really focus on preventative care, ideally, we could keep them out of the hospital, allow them to live fruitful lives, carry on a family of their own if they choose to, carry on a full career. And so this is something that needed to be fixed. And so as a result, CHOA and Grady had developed a transition program many years ago, which now I have been tasked as the medical director of the transition clinic to kind of revamp and revitalize. Because of this number of 40 to 60%, our goal is to get it to 100%. So what is a transition program? A transition program is something that maybe you've heard of before. It's not unique to sickle cell by any means, but it's a systematic process that starts in young adulthood or even teenage years and moves on into the early ages of adulthood, that focuses on all sort of activities and interventions that will improve the success of moving from the pediatric to the adult world and also make that as seamless as possible. So starting at a young age, what we do in the CHOA sickle cell program is we ask you as a 13-year-old, what's your genotype? What is sickle cell? Then as you get older, when you're 16 or 17, do you want to have a family? Do you know the inheritance pattern of sickle cell? When they're 18, you know in a couple of years your insurance is going to change. So how will you manage that? How will you make your own appointments? When they come to me on the adult side, we talk about what's your career look like? What do you want to do for the rest of your life? Do you want to go to college? Do you want to get a labor job that doesn't require a college degree? If so, how will you manage what will happen if you have a crisis? And so these are the things that we kind of talk about in increments as they age into young adulthood. And so the beautiful thing is that this is very well poised for an individual who's Med-Peds trained, right? Because I am able to see pediatric patients between the ages of about 13 and 18 twice a month on the pediatric side, and then once a week I see young adults, including today, where I focus on young adults with sickle cell disease and really help them as they manage this really complicated transition from pediatric to adult world. I understand the complications of the pediatric side, I understand them on the adult side, and now I get to focus on how that individual can take control of his or her health as they move from those two care worlds. It's truly a lifespan career, which is very amazing and very true to Med Peds. So myself, I'm part of the Med Peds sickle cell group. Dr. Prashanth is another gentleman who is Med Peds trained from MUSC, and he mostly focuses on hemostasis thrombosis, but definitely helps in the sickle cell realm. And then Dr. Ross Fasano I threw in there, who's not a formally Med Peds trained individual, but he did a Peds Hem-Onc fellowship and then followed up with an adult transfusion medicine fellowship. So he sees adult patients on the Grady side and pediatric patients on CHOA. So we've kind of inducted him into Med Peds. But the whole point of this is that, the concept of a transition clinic is that it's very well poised to be taking care of somebody who understands and appreciates lifespan. So thank you so much for letting me share my experience.
Awesome. Thank you, Dr. Aurora. That it's amazing and inspiring to see you use your training to its fullest extent. The other thing that I think we can offer to healthcare systems is workforce flexibility. So this was exemplified very well during the pandemic when there were so many adults who were critically ill. A number of MedPeds hospitalists were redeployed to different spaces because they had that flexibility. And then when the triple-demic happened the following fall in the pediatric space, we just redeployed right over to that other space. So we offer a lot of economies in staffing. You get a 2-for-1 when you hire a MedPeds physician. And we're very helpful in bridging gaps in complex care transitions, which Dr. Rutledge is going to talk a little bit in just a second. And lastly, we add a lot of adaptability to our teaching, to our clinical care, to our research, to academic spaces as well. So I'm going to transition to another example of MedPeds in our workspaces, exemplifying a little bit about workforce flexibility. So I'll turn it over to Dr. Rutledge.
Good afternoon. Thanks so much, Katie. So today I get the opportunity to highlight the Pediatric Consult Team. And this is a new program that really harnesses the unique skill set of MedPeds providers. So a little bit of background. Not a lot of people are aware of this, but Grady actually delivers care to a very large pediatric population through its emergency and stabilization services. But it also directly admits pediatric patients through the ortho trauma teams, the obstetrics and gynecology teams, and the burn care departments. And as one would expect, as the census in these services has grown, so has the need to examine how to effectively and comprehensively provide pediatric care to these patients. So over the past year, with the support of a multidisciplinary team of surgical providers, as well as the Grady Hospital Medicine Department and Dr. Joanna Bonsall, Chief of Medicine at Grady, I set out to determine how the construction of a pediatric consult service could meet the needs of young adults and children at our hospital. Next slide, please. So in early 2025, I had the pleasure of speaking with stakeholders from across the hospital, including nursing leadership from burn, specialists from child life, and physicians from Morehouse Family Medicine, the Grady Emergency Department, trauma, ortho, the Marcus Autism Center, and the Grady Neonatal ICU to familiarize myself with this pediatric landscape. And from these conversations, a lot of common themes arose. So the first was that all members really wanted to provide excellent care to pediatric patients, but often felt that their teams could benefit from additional training and support to ensure safe care. Also, providers noted that they desired having standardized pediatric protocols to take care of patients, and they understood that you can't just adapt or extrapolate adult guidelines to pediatric situations because it's not always effective and nor is it always safe. And teams such as the emergency department and orthopedics and burn stated that if they had access to the advice of pediatric subspecialists, that this would often prevent them from needing to transfer patients from Grady to another outside pediatric hospital. And with this support, they felt that there could be more pediatric patients that could be safely taken care of here at Grady. And lastly, many pediatric stakeholders really lamented the fact that they felt siloed and wanted to collaborate with other colleagues to address the longstanding concerns within our pediatric population. Next slide, please. So as of September 2nd, we now have a fully staffed consult service that can evaluate all admitted patients 18 years of age and younger, Monday through Friday, 7 a.m. to 5 p.m. And we do not see patients in the neonatal ICU, which is separate, or the newborn services department. And so our team is run by 6 amazing MedPeds trained physicians. And in true MedPeds fashion, they wear many hats. Um, Next slide, please.
Mhm.
Oh, one more, sorry. So these are doctors who were already employed at Grady as adult providers, and they've been redeployed to meet the increasing needs of Grady Hospital as we grow. We have 3 members of our team who have inpatient clinical appointments at Grady and also at Children's Healthcare of Atlanta. So that's Dr. Argis, Dr. Gielissen, and myself. And 2 who are leaders in procedural medicine, Dr. Hillhouse and Terwilliger, and then also Dr. Zaros, who has expertise in pediatric emergency care. Next slide, please. And so our team is really only a month old, and so truly in our infancy. But as we look to the future, we hope to continue strengthening the pediatric infrastructure at Grady and to begin forging partnership with subspecialists at CHOA. And simultaneously, we want to continue to contribute to the already existing working groups that we have at Grady that are working to standardize these pediatric care protocols that are necessary. Eventually, as our team grows, we hope to discuss the benefits of what a pediatric or young adult treatment team could look like, because as Dr. Aurora's work demonstrates, MedPeds physicians are well suited to support the transitional care of adult patients with a history of pediatric chronic illness. And as we solidify this model of a pediatric team within an adult hospital, we look forward to expanding and replicating this model beyond Grady. Thank you.
All right. Thank you so much, Dr. Rutledge. So because I get this platform to talk about things, I'm going to absolutely talk about the amazing program that we're building here at Emory, and tell you a little bit about the strengths that we're bringing to the table. So here are my folks. One thing you may not be aware of is that this is not the first MedPeds program that has existed at Emory. You may not be aware that there was a MedPeds program here previously. I had to dig through the old AMA green books that are like all uploaded online and scanned in their glory. And if you look at the 1974-75 book, you'll see a category called Informal List of Flexible Programs. And under that category, you'll see one program listed at Emory. So the Georgia Atlanta Emory University Affiliated Hospital MedPeds program. And you'll see some familiar names as the assigned program directors. So J.W. Hurst, now the namesake of our internal medicine program, and R. Bloomberg, who was a very prominent name and now has an endowed professorship in his name. The MedPeds program continued to be listed in the Green Book until 1983-84. This was the last listing that I could find, where we were listed as having 6 positions and the program director was listed as George Brumley. So there was a program here. Unfortunately, it did not persist, but we are back, and we are very strong, and it's very exciting to grow a new program here. We have a strong mission. Our goal is to generate physician leaders and who are change makers in their communities primarily. So we're very much focused on the care that we deliver both in our clinic and at Grady amongst the other hospital systems we work in. Many people ask me about the structure of the training. So we are very fortunate to have an entirely MedPeds leadership team. We have 4 residents per year. Our residents will be rotating in and out of medicine every 3 months. So you'll see them go for 3 months and then they'll come back and work with you again. We're in a combined clinic, so we see adults and children precepted entirely by MedPeds physicians in a federally qualified health center. And we are the only MedPeds program in the state of Georgia, as Tarun mentioned earlier. All of our neighboring states have 2 to 3 programs, so we were quite unusual in that respect until our program opened up. Here's our amazing program leadership. I'm very grateful to every single one of them for being such great partners in building this program. So aside from Dr. Rutledge, we have Dr. Pinto Taylor, who serves as the APD of the program, Dr. Sonu, Dr. Argis, and Dr. Lee, who are all incredible leaders and have been really helpful in building this and very inspirational to our residents. And we have honestly amazing training locations. So I'm sure many of you are very well aware of how special Grady is. I will say that we have the perfect mix for a MedPeds program. Many MedPeds bound students are interested in being at a public safety net hospital, but also want to be exposed to a tertiary care hospital for their internal medicine training. And we really have that in spades here at Emory. But I wanted to take a moment to highlight children's because I think that's a really special component of our training and adds to our strength. So some of the best MedPeds programs in the country have an associated freestanding children's hospital. And many of you may not be aware, but with the opening of the 2 million square foot Arthur M. Blank Hospital, we are now the second largest freestanding children's healthcare system in the country. We are huge here in Atlanta, only second to the system in Baylor. So we are really, really large and very well poised to provide amazing training to our trainees. I also would just love to highlight a new partnership with a federally qualified health center. So combined MedPeds training in a primary care space is really important to us. And I'm really grateful for the leadership from Dr. Del Rio and Dr. Law, who have helped to create this partnership with this federally qualified health center. And it is such a privilege to care for the patients that we care for in this wonderful clinic. And then here are our people. So if you have the opportunity to work with a MedPeds trainee, we have 4 amazing interns, Peyton, Julia, Ryan, and Nastia, and 1 PGY2, Miriam, who many of you will get the opportunity to work with over the next 4 years of most of their training. Lastly, I just wanted to highlight a few things that I perceive as potential threats to our training as we move forward in the future. So one thing that has been challenging for us is that there have been increasingly strict requirements, particularly from the American Board of Pediatrics, in regards to the type and the amount of exposure to certain things during our pediatric aspect of training. We just had our new program requirements get published, and they really restricted the amount of flexibility that we have available to our trainees. And as I've tried to emphasize multiple times, flexibility and versatility is really what defines us as a specialty. So that has caused some issues. Secondly, there has been an emergence of a new board certification on the pediatric side. So there is now a fellowship in pediatric hospital medicine that has an associated board certification. And increasingly, academic hospitals and pediatrics are asking for this board certification to do pediatric hospital medicine practice. And many MedPeds folks feel very well trained in hospital medicine. And also, you can graduate out of internal medicine training and become a hospitalist immediately. So it feels a little bit strange to do a full fellowship. So that has caused some waves within our specialty and generated a lot of discussion. Nationwide, there's been a decreasing interest in pediatrics overall. That hasn't touched our specialty specifically, but fewer and fewer people are choosing to do pediatrics. And there's many factorial, but I think one of the big drivers is how the pay inequity that exists between pediatrics and other specialties. And then lastly, depending on the institution, sometimes it can be very hard to secure combined jobs. So when you have 2 different departments negotiating, 2 different sections negotiating, sometimes that can create a little bit of bureaucratic red tape, making it challenging for us to have the flexible jobs entering into the clinical spaces where we're hoping to enter. So in summary, MedPeds is a thriving specialty with a very long history. We're 58 years old as a specialty. And we can fill in special care niches and workforce flexibility within the Emory, CHOA, and Grady systems. And the emergence of a program here is very emblematic of Emory's health and very strong training opportunities. So with that, I'd just like to acknowledge, of course, whenever we're involved in MedPeds, as alluded by Dr. Rutledge, collaboration is our big key. And thankfully, we have many leaders across the 2 different departments that have been incredibly supportive. I'd like to highlight Dr. Del Rio, Dr. Armstrong, Dr. Log, Dr. Swales, and of course, my partner, Dr. Rina Hemrajani, for being wonderful co-collaborators on building MedPeds here at Emory. And of course, the pediatrics leadership as well, Dr. Barkin, Jane, Warshaw, and Sanders. And then many MedPeds faculty. The folks I have listed here are individuals who have helped to support an elective for students who are interested in MedPeds, and I'm very grateful for the time that they've contributed to help inspire our new graduation, our new generation of graduates. So with that, thank you very much, and I'll take any questions along with Dr. Rutledge and Dr. Aurora.
Thank you, Dr. Gielissen, for that excellent presentation. It was so helpful to learn some of the history, especially a lot of the nuanced history that you clearly have so much expertise in, and to hear about where y'all are going with this incredible program. What question? Looking through the chat, just a lot of affirmations, amazing talk. Happy birthday.
Yes, it is my 40th birthday today. Thank you very much, Dr. Dunn, my longstanding mentor from Yale.
What questions do y'all have?
Dr. Lee is promoting his fellowship. Good job, Dr. Lee.
Very happy about the start of the residency program. Can you talk about increasing interest in our medical students?
Oh, yes, there is. So we're really grateful. I think one of the things that's been really wonderful, I think the many impetus behind starting a MedPeds program here at Emory, one of them was ongoing and persistent interest from students wanting to apply and match into MedPeds here at Emory. And many of those students were incredibly talented people that we would love to have the opportunity to retain, obviously. So it's been lovely to be able to help to mentor and foster their interest in MedPeds. I think we've been especially inspirational because there are quite a few applying, nine in total applying MedPeds from Emory this year. So it's been very exciting to be able to see that excitement. And hopefully over time we can build more capacity for additional trainees to join our program. Hopefully that answers the question.
Dr. Law asks, for the faculty on this call, what needs can our teaching faculty help with in your curriculum, program, etc.?
So obviously, our MedPeds folks want to be exposed to the full contingent of internal medicine and pediatrics training. So my first advice for anyone working with a MedPeds trainee, whether it be on the general medicine wards or in subspecialty service, is to treat them just like an internal medicine resident in every possible way. But we also have research interests. Just because we do focus on both populations, oftentimes we want to get exposure to whatever research that you're doing because there's opportunities for us to translate that to the care that we provide. So my summary statement is treat them like internal medicine residents. Sometimes we bring other perspectives to the table and be open to those different perspectives, but we definitely want to have the same exposures, the same opportunities because we're expected to be able to practice the same medicine as an internal medicine trainee.
Great showcase on all things MedPeds. What future goals do you and the MedPeds team have with extending the reach outside of the programs you mentioned?
I mean, there's so many different clinical opportunities, Malachi, for MedPeds at this institution and unfilled spaces. So transitions of care, I would say, is one of the biggest opportunities because right now, children's and EUH and Grady tend to be pretty siloed. And there are some challenges in getting care across those silos. So things like pediatric rheumatology, there are some individual programs to support people in that transitions. Like I believe there's a lupus program that's active, but I think there's even more opportunities to make sure that those transitions are safe, structured, and feel good for all parties so that those families and those patients can be supported in that transition that can be so dangerous. I don't know, Tarun didn't mention this, but like mortality actually goes up for a lot of these childhood illnesses when they transition to the adult space, sickle cell included. So it can be a really challenging time for many folks as they make that transition. Any other thoughts about that, Tarun?
No, I think that you're absolutely right. And I think it's a great place to focus because so many of these chronic illnesses, hemophilia included, they weren't expected to survive past their 13th, 18th birthday, and now that's changing. And so MedPeds's transitions of cares is huge. And I echo what you said about research too. So I don't know, we didn't talk about research here, but it's nice because the research I do and many MedPeds do, it bridges that gap again between the silos of CHOA, Emory, and Grady by having routine research meetings with my colleagues across all campuses. I think it brings together the community a lot better. An unintended consequence, but a good one.
Yeah, we recently had one of the combined fellows, HEMONC fellows, come and talk with us, Josh Muniz, and he was talking about how he was applying some of the algorithms for pediatric cancers to young adults and how the outcomes are better for those individuals. But that's an area that needs intense research in order to show its efficacy. And it's just a really, there are many, many different niches, research spaces that could potentially be filled by this skill set.
Is there a proposed explanation as to the discrepancy where hospitalist fellowship is required for peds but not adult hospital medicine?
Annie, I could talk for 2 hours about that. One chicken and egg, but the PEDS requirements have changed to be more general pediatric outpatient focused, but that was after the PHM board certification came into existence. From what I understand, primarily the drive was to create a separate identity that's as respected as any other specialty in the pediatric world. Unfortunately, what it results in is 2 additional years of training for that individual without increased pay necessarily. So I do wonder how sustainable it would be for individuals, even in categorical pediatrics, to choose to do 3 years of pediatric residency and know that the only thing you can do out of that is to be a general pediatrician, which I think is definitely driving some of the decreased interest in pediatrics nationwide. There are many other things that are driving those changes, but that's one of many.
Dr. Hall mentioned that they have a few applicants to endocrinology fellowship this year who are med peds. What kind of space is there to build community for all of our med peds residents and fellows?
I have a living list of every single person that has reached out to me who is MedPeds trained, and we very actively invite them to come join our program, teach us, join us in our social events. It's been honestly wonderful to hear from the various folks, fellows and faculty, and their excitement about fostering and mentoring our new generation of MedPeds. So it's very true. Dr. Manning, it's so true.
Dr. Manning asked, do you have any concerns about attrition to categorical residencies from med peds?
No, I don't have any concerns about that. I think people choose what's right for them when they match.
Dr. Higgins asked for Dr. Rutledge, any plans to compare outcomes of peds patients with the consult service versus those who do not have the consult service?
Yes. So I think one area that we found among the pediatric patients that interface with the consult service is that there's really poor linkage to care. And so, what I'm interested in determining is given the involvement of MedPeds physicians from hopefully the beginning of their admission throughout and then till the end, is how successful are we in being able to reconnect them to pediatricians and to their outpatient subspecialists that are needed. So that definitely is in the works. Thank you.
Any parting questions as we wrap up because we are at time? All right. Thank you, Dr. Gielissen, and the entire team. Thank you for this excellent talk, and thank you for all that you're doing for our trainees and for our medical community. Thanks all for being here. We hope you have a great rest of your afternoon, and we will see you next week. All right. Bye, all.
Thank you, everyone.